We go ahead and get started. Thank you all for coming. As you know, can you turn down the volume a little bit on this so it doesn't echo? As I always state, our conference is normally on Thursdays, but when luminaries come to visit, we move it to different days of the week. So we have a luminary here today, and he's Dr. Enrico Coiera. If you've never met him, you've probably read his papers or heard of his papers. Very well known in the field. He also has recently published the third edition of his textbook called Guide to Health Informatics. Enrico is, as you'll tell when he starts talking, from Australia, and he's currently director of the Center for Health Informatics at Macquarie University in Sydney. And he received his medical degree from the University of Sydney and PhD from University of New South Wales. So you're probably wondering why I put this slide up here. So about 11 years ago, I happened to be in Australia. I was actually in Melbourne, but he kindly had me come down to Sydney. You can see I look a little younger there. But these are arguably, or maybe not arguably, the three most prominent informatics researchers in Australia. Johanna Westbrook, some of you probably know of her work. She's also, I don't know if anyone's here who's on our Health Information Exchange project, but she's on our technical expert panels, and she dials in at 9 a.m. Pacific time, which is something in the middle of the night. And Farah McGraby, who's also done very interesting and important work in the field. Then some other guy from OHSU, and then my daughter, the one who's starting medical school this fall, who I took on that trip, who was 13 at the time. And you can't really tell too well from this picture, but his office used to be in this house that was a half-mile from the beach. And we were there in December, which is like late spring in Australia, and it was just incredible. But now he's moved on from University of New South Wales and doesn't have quite as nice of a venue, but he continues to do very impressive work. So I will switch over to him and let him talk. And as with all of our talks, we are streaming live, and if any people out in cyberspace want to ask any questions, just send it through Twitter to #DMiceConf. So, Enrico.
Thank you very much. Good morning, everybody. And when I say good morning, I really mean it. It's 2 a.m. for me. So thank you very much to Joan and Bill for bringing me out, and I'm looking forward to the Manuka conference. It's going to be fun. So from one city of bridges to another, so I feel at home here in Portland. We have seawater under our bridges. But what I thought I would do, before I started the talk proper, I thought I would sort of do a speed dating thing and introduce you to who we are in our group and give you a sense of the work we do. So if the substance of today's talk is not right in your area, but you hear about something that you're interested in, then maybe we can chat afterwards. And I know there's some time set aside this afternoon too, or send me an email. So we all live under the umbrella of this Australian Institute of Health Innovation, which is 100 research scientists, totally committed to research, health services, and probably 70% informatics, e-health. So a very, very large group. And we've been running really as individuals for nearly 15, 20 years now, so it's been around for a long time. Bill's mentioned already Joe Westbrook, and so we have three large groups within the Institute. So Joe's group is focused on the impact of implementation of e-health systems, workflow impacts, interruptions, multitasking, interested in aged care increasingly, and a strong focus on evaluation. So really great work comes out of Joe's group. Jeffrey is the non-informatician, the token health services researcher, and his focus is around system resilience, implementation effects, organisation, culture, etc. And he's got a couple of books out now on healthcare resilience, which have, with Eric Holnagel, which have just been published. So I direct you to them. And then there's this lot over here. By the way, I remember my first trip, Bill, to the US when I was at HP Labs, and we met somebody at the gate. She said, "My God, you've got an accent." and yeah, you have, ma'am. So this is my group. And my group's focus, I mean, it's very hard when you do informatics and do research to say you have a single theme, but our focus probably is on supporting decision-making in one way or another. And the focus is really because of all the interventions, you know, telemedicine, records, the one that has the biggest impact on outcomes time and again in study is the decision support system. So we really know if we get this right, we're going to make a difference. But equally, you know, every EHR has rules and alerts in there. We've built expert systems for decades now. So the research agenda has changed. And what is our focus? You know, so I call it next generation decision making research. You know, there are new decision makers out there. It's no longer the doctors, it's the nurses, it's the consumers. We're no longer focusing on therapy decisions or diagnosis. We're using online systems for CBT, for e-mental health, etc. So lots of different decision classes that we're looking at. No longer just looking at the EHR for data sources, wearables, augmented reality, social media, just so many different things that we can feed into the decision support systems. A strong focus also on personalisation, so not just patients like me, what should I do, but patients like mine if you're a clinician, what should I do with this patient compared to other people who have been in a similar situation. And as Bill said, focus on safety, which is, I know, one shared with researchers here, so making sure we do no harm with the IT. So of the first group, this is the one I'll be talking a bit about later on today, and this group is focused really on the notion that we can use sources like the EHR as a new source of evidence. You know, when we don't have RCTs to provide evidence, then the best evidence is the observational record over the last, hopefully, 10 or 20 years. And so this group here is working with Chris Longhurst on the green button technology, which is really all about finding a patient who's just been admitted for you and saying, look, I don't have any RCTs, you've got multimorbidity, what do I do for you? Or it might be a rare disease. Let's find a matched cohort from that record that we know historically that has been very similar to you based on some similarity metric, and let's predict what the most likely course of therapy or treatment will be for you. You know, this is called green button technology. I don't know why it's called green button technology, but anyway. The other thing that the group is doing is dynamic real-time forecasting. So in the same way you get a weather report, imagine you're admitted, and the idea is we don't just say your risk of death on admission is 0.2. We say, here's the envelope for your length of stay, for your risk of infection, for your risk of death, for your risk of readmission. And so people can look at that probability shape over the next week and say, okay, what should we do around care there? So very interesting stuff, and happy to talk about that later on. The next group, I think, has strong resonance with some folks here too, which is we have a strong interest in manipulating the published literature. So we're calling that Computable Evidence Lab. And the idea here is that the business of systematic review is a broken business model in a way, that it's very hard to keep up with literature, let alone to synthesize it. And if you're in Cochrane, Cochrane is way behind its to-do list. So we're very interested in how we can bring informatics to the process of supporting reviews and ultimately just having systematic reviews at the click of a button. What's the research say today for my patient? Which sounds ambitious, but when you break it down, systematic reviews have defined steps, starting from search, something that maybe Bill, a little bit about, all the way through to extracting the data with text mining tools, doing the synthesis and then generating the reports. And when you break it down, it turns out that we have a lot of the technologies already in place. Our challenges really are around extraction of the right elements. And it turns out that doing this, the meta-analysis itself is already a done deal, and generating reports is just template-based. So really it's just that extraction and a little bit of the synthetic task that's missing. The other big problem we have really is the literature itself is in bad shape. So a lot of the research that's relevant, was published a long time ago. We didn't have as well-structured RCT reports, for example. So that's our problem there, which is dealing with the legacy of poorly formatted previous studies. Again, happy to talk about that later on if somebody's interested in that area. The next area also deals with evidence, and this is a co-authorship map. So these are co-authors of systematic reviews for Tamiflu. And you can see the folks in blue all co-publish, and the systematic reviews they publish tend to suggest that Tamiflu is of not great value, shouldn't really worry about it, doesn't make a difference. The guys in orange tend to be very positive, you've got to use it, you've got to stockpile it nationally, blah, blah, blah. And you can see that there's very little relationship between the blues and the oranges. Any guesses about what the colours mean? Any guesses of what the labels might be? Folks on this side are pro-Tamiflu, folks on that side are negative. This is not a hard question. Correct. This is a conflict of interest map. Everybody in orange has been funded in some way by the manufacturers of the drug. So we've known for a long time that trial data is compromised or biased. This is evidence that systematic review data is biased. So this came out in Annals a couple of months ago, if you're interested. And so this stream of work really we call evidence surveillance. We're really looking at evidence as published, looking for early signals that there are biases or in fact, in the case of Tamiflu, we're not even making a judgment about whether the evidence is good or bad, but that there's a clear divergence between groups about what's good or bad. And so that's just a signal that there's a problem in the evidence base. It doesn't say necessarily that there's anything wrong. And so this is not sort of saying pharma is bad, pharma data is bad, but there's an issue. We're also interested in how evidence is processed by people once they read it. And so, for example, I know it's very topical here in the US, we're looking at anti-vaccine sentiment in Twitter streams and just trying to see how amenable the anti-vaccine groups are to messages about vaccination. And it's very interesting. When you look at what the community structures online, they are very insular, very, very self-referential, do not look at evidence beyond the other groups. So at least the social media analysis suggests that if you want to target these folks, then they're not susceptible to generic public messaging at all. They already have their own communities, and you've got to find different ways in. So very interesting stuff, and I think we have a paper in JMIR coming out soon on that. Bill mentioned Farah Maghrabi, and Farah's interest has been in safety v health. She's been looking at incident reports, safety incident reports related to IT harms, and has looked at it, I think incidents from Australia. Also, we managed to get into the FDA and pull out a whole bunch of stuff. And 2 years ago, the English NHS gave us access to all of their safety reports. So we've just published a paper in International Journal of Medical Informatics looking at the safety reports in the NHS. And the big feature there is large-scale failure. So in other words, 20,000 patients get the wrong letter. So that's very interesting. So Farah has beavered away over the years and developed a classification of HIT errors, and a lot of them are socio-technical, not just technical. And that classification, I mean, I know this is a bold statement, but it's now used as the basis of lots of reports. So Pennsylvania Authority, ECRI has used it. This is Wales, etc. So it's not complete. There are other views on how you would classify it, but it's getting wide use. So I think it's a great contribution from Farah. And the last group is consumers as decision makers. And we've had a platform called Healthy Me, which we've had now probably for about 7 years, which is for researchers where you can take a toolbox and provide different consumer informatics interventions, whether it's to provide social networks for clinical evidence, pathways, guidelines. And our interest has been in whether or not you actually can change outcomes. There's been a lot of studies around adoption, but very little about impact. And so we've done a whole bunch of RCTs and trials, and I just want to point out two that are of relevance. One is on flu vaccination, where we managed to double vaccination rates by giving people access to this tool. And we've had a very similar finding in STI screening, getting young adults to be screened, again, providing this stuff. So it does show strong evidence. Interestingly, we've just finished an RCT on adult asthma populations with no impact whatsoever. So it's not that this is always going to work. And we're trying to understand what it is about the nature of the task, say, with adult asthmatics and getting them to be on action plans for exacerbation and these screening things. And our guess is it has to do with having lived with a disease for many, many years. You already feel like you know what you're doing, even if you may not necessarily do so. Okay, that's the end of the speed dating. This is to remind you that, therefore, that what we do in Australia is very similar to what you do, but there are little Australian tweaks to it. So we're the same but different. We're also relaxed. I noticed this guy's got solar panels on his ears. I'm not sure what that's all about. You can see why they could hurt you, can't you? Look at the muscles on this guy. He's a strong fella. Okay, to the talk itself today. And today's talk is one on analytics, but it's not going to be a technical talk. I'm going to talk through examples. I'm going to give you 2 case studies and really talk a lot more about approach to analytics and clinical data because I think the challenges we have are much less in terms of data quality or the tools, but really in the great challenge at looking at large masses of data sensibly and meaningfully. So the focus is on temporal patterns of care, and temporal patterns are well known to us in healthcare. At patient level, you know, we use the time pattern in an EKG or the order of symptom presentation. We just know that these are very important signals, and we know that, you know, there are all kinds of seasonality patterns that are really important. So there's nothing new in the idea that there's an unfolding temporal pattern to data. And okay, this is just annual death rates in my country. And so what's going on in July? Shark attacks. What's happening? Why are we all? What are we doing here? Are these tourists drowning?
Are you on the same schedule that we're on?
No, we're not. That's right. That's the winter season for us. That's the flu. That's just yeah, right. So you're thinking July summer holidays? No, it's just 6 months out. So it was a trick question. Well done, Professor Hirsch. And of course, if you look at that signal over time, you see it's regular but different. So our interest is not in those data, but in health service data, process data, the sort of detritus of day-to-day life that you would generate as a clinician as you go through your act of ordering medications, ordering lab tests, looking at workflows. What are the signals and patterns in the data of our practice? That's our interest. And you know, my sense is, you know, we understand the physiology of the human body really well. You know, there are Starling laws about how the heart works, but we don't really have the same laws yet around how our organisations work. There need to be basic processes that underpin them all, but we still sort of see health service delivery not in the same way that we would approach clinical data sets. So why bother? Well, number one, just knowing when you need to allocate resources, staff, the kinds of staff, is going to help you deliver a better service. But it's got a big impact on patient quality and safety. So you need to make sure that the services you need are available when they should be here. You want to avoid harms. You want to make sure that if something is needed, it's available. So it really is not a small problem, especially when you look at iatrogenic causes of harm. What we're doing in healthcare delivery is something worthy of study. So the first case study, and this is probably a problem well known to you, isn't it, which is the issue of test order follow-up. Just because a test is ordered doesn't mean anybody ever reads it. So that's understood, I think. And the data out of the States is between 20 to 60% of inpatient tests are not followed up. I still find that figure hard to digest. I'm not quite sure I believe it, but that's what individual studies seem to show. And it's not just an economic disaster, is it? There are important consequences. You know, nearly half of your malpractice suits with diagnosis come from failure to follow up. And a lot of those tests are clinically significant. Those that are not looked at carry data that may have changed care. So our question really was, well, what is underpinning this failure to follow up in hospitals? You know, are there any laws that govern what's happening here? Bad systems, bad clinicians, Something else? What's going on? So we were very lucky. We worked with one of our teaching hospitals which allowed us to timestamp everything from the moment an order is generated or a lab is generated to the moment somebody clicked on a view result. So we could see the whole process from lab receiving it, when the lab finishes with it. So we had all sorts of metrics for time that we could look at. And that really made the study possible. And you could just see here, it's mainly internal medicine surgery. So what did we find? The first result is very high level, and the failure rate is around 3.2% at discharge, so not 60%. And I don't think we're any different to the States. I just think once you measure it more accurately, you're going to get more realistic figures. And 2 months out, it sort of halved. This is the figure here that was a bit disturbing. So 40% of patients had at least one test that was not followed up. And 20% of those unreviewed tests were abnormal. So, that points to an issue. And at this point, to be honest, my team probably wasted 6 months where we looked at the data by test panel, by physician, by specialty, by whether it was normal or abnormal, just to look at associations. And at some point, we really got stuck because you can imagine this is a very large data set in some ways, and there was very little information there. So at this point, I said, guys, we need to stop. We need to think. We need to think from first principles. We need to have some hypotheses about what this data set is going to show. We have to have some understanding of clinical practice before we come and look at the data. And I'm not a great fan of just looking through data sets for statistical associations. I think you need to have something in your head. So what's going on? I mean, at the top level, you've got two. Yeah. Oh, sorry.
On the last slide, just explaining the discrepancy between the first two results.
Going back, which ones?
Just the 3% versus 40%. I just didn't quite understand the distinction.
So my guess is that the 40% results are based on estimates, and we were in an unusual circumstance where we're actually being able to directly measure what people did. So being able to measure every time somebody clicked a button and saw the results. So those earlier studies were not based on being able to directly measure what's going on. It may be the case that Coiera is worse in the States, but I don't believe it. And it would be a shock to me if your results were not similar when you use the same measurement. So, if you use a different methodology, you're going to get a different number. And my guess is this is a more accurate number. Does that help? Yeah. So, two big highlights. One is that simply people are ordering tests that are unnecessary, and therefore that's wasted money, and they're not following up because they didn't need them in the first place. And the second set of hypotheses are that, look, these are necessary tests, but somehow they got missed. Maybe the doc didn't know the test had arrived. Maybe they were too busy or understaffed. Or sometimes they actually did get the data, but they didn't get it through the way we measured. Maybe they got phoned up by the labs and were given some information. And actually for urgent things like potassiums, that was the workflow in our lab. But even that is sort of complicated. So the question really is, how do you look at data sets which are not designed to test hypotheses? This is observational historical data. This is not an experiment. And so our approach was to say, look, there must be temporal signatures which distinguish one hypothesis from another. So for example, let's say I'm ordering tests I don't care about, then as time goes on, I'm just not going to change my behavior. I'm always going to be ignoring those tests. If I really wanted those tests, then over time, I'm going to start to get to them. So you can imagine that there will be a change in pattern. But I said, let's start with the most basic hypothesis we can think of, which is that this is just driven by workflow. This is just what happens as a result of the way this system is built. This is the result. They're saying systems deliver the result they were designed to do. And so my first presumption is that this failure to follow up is a natural property of the way we deliver care. And if that's the case, then the most simple temporal hypothesis is that follow-up rates are dependent on how long a test is available for review. Clearly, if a test has just been there for 10 minutes, its chance of review is quite low. It's been there for 10 days. Someone's had a chance to look at it. So I said, let's just line up the data. When was the test ordered? When was it read? And what was the gap in time? And what does that graph look like? And this is what we got. So I'm not claiming it's the Starling law, but very interesting. So clearly, any test that's been available for a long time has a very high chance of being reviewed. These are tests that had a very limited chance to be reviewed. And you can see that's where the big failure to follow up happens. So what's going on? So these are day of discharge orders. And you can see nearly half of the tests that were never seen were ordered on day of discharge. Very interesting. And when you look at follow-up rates, so you can see a discharge day test has a 21% chance of being missed compared to 1.9% for other ones. So a huge difference. So half of the problem is probably a workflow problem to do with why is this test being ordered on the day the patient is leaving. And that study came out in Archives a couple of years ago. So, you know, that still needs to be tested further, but it changes the focus of your thinking. You say, okay, now, so it's not about bad docs, it's not about bad processes, it's about how we coordinate discharge and how we coordinate test ordering. You know, discharge planning should incorporate plans around tests. You know, you shouldn't be able to order a test that's going to take 10 days to return when the patient's got 2 days of inpatient time left. This is where you can connect discharge planning to alerts, you know, letting people know how long it will take before a result comes back, or saying, you may not know it, but the patient's going home today. And the other part is going back to the consumer. So the consumers also need to know when they leave hospital that there are still pending tests. They need to be able to maybe talk to their primary care physician and say, look, I know that I had a chest x-ray on the day I left, and we need to follow that up. The other thing is about the handoff that happens at discharge. Once the patient is discharged, people think, well, my job is to get the discharge summary done, wash my hands. But what this says, no. This says, look, there are still tests coming through the pipeline, and we need to let you know about that, and you may need to act upon those things. So we're again, you alert people about important results that have become available a few days later. So that was really interesting. And to me, the lesson there really was about not getting lost in the data, thinking about first principles, what might be happening in the process. And this only explains half of the problem. There are other things going on, but that was, I just thought, a very, very interesting result. So the second case study is weekend effect, which I'm sure you know about. So this is, you know, your risk of death is higher if you're admitted on the weekend, which always is a disturbing thing to say. And there are really two explanations that people worry about. The first is selection bias. In other words, the folks turning up on the weekend are sicker. They're dying more because they've got greater acuity or whatever. And the second is that we're not doing such a good job on the weekend, that we have lower staff rates, that we don't have the same staff on, and that somehow there might be higher rates of iatrogenic harm, or people aren't getting what they need. And one interesting clue comes from some of the studies which have happened in the past, which look at ED and intensive care, and they suggest that if you're running a good 24/7 service, then the weekend effect doesn't really seem to affect those units. So we set off again to look at observational data to help us try and tease apart these two big causes, because up until this point, no one's really been able to answer which is it. And this paper came out last year in BMJ Quality and Safety. And so just to give you a sense, I don't know if you can read it, but these are the past studies that we had at the time which looked at weekend effect. And you can see the odds ratios for death are all showing weekend effect. And a lot of the studies are looking at patients with stroke, PEs, ruptured aneurysms, etc. Very few looking at the whole population. but all pointing to the fact that there's something going on. There are a couple of studies that seem to say it doesn't exist, and they're the ones that make us wonder what is going on. So this was a much bigger study. We had access to our state's public hospital system, and most care in Australia is through the public system. And so we had access to about 3.3 million admissions, 530,000 patients. And we also linked it to the death registry because we wanted to capture deaths that happened post-discharge. Just because you've gone home alive doesn't mean we've done a good job. So we wanted to make sure that 1 week post-discharge, if you died, we also captured you. And then what we did was we just compared weekends to weekdays and tried to see if there was any excess mortality. It was one different to the other. We did all the adjustments you need to do for age, sex. We did Charlson Index for comorbidity, and for the diagnostic group, the DRG. So about as good as you can do for observational data. And again, let's look at what the high-level data showed. So a small difference in death rates favouring weekends. So weekends are worse. So you can see it's about 2.1% versus 1.8%. And these are important differences now because we're dealing with millions of patients. So these are lots of people in these very small numbers here. Interestingly, when we looked at DRGs, only 16 accounted for, had a weekend effect. But they were the big ones, so nearly 40% of deaths. So again, what is going on? Here are the 16 DRGs. We struggled to find a pattern here. Any patterns occur to you when you look at this? It's a bit of a mixture, isn't it? It's quite a mess. You've got cancers, you've got some cardiac events, some pulmonary events. The answer is not much. There's not much you can say based on disease group. And again, I have to say, the team doing this has probably spent 9 months looking at the data, again, looking at associations, again, getting very lost. Everything they looked at, didn't seem to make a difference. So again, go on.
The one thing I don't see on there is any kind of infections.
Correct.
So that's the one thing that, it must be intensity of service requirement. That's one hypothesis. So for infections, you put them on the antibiotics. They're pretty good at giving those. But for these other things, the complications that can occur, the sort of need to monitor might be much more intense.
Yeah, it's possible. So we'll see how that unfolds and see whether you're right. Okay, so again, I said let's start from first principles. Let's imagine that we have these two competing hypotheses. One is poor quality of care. Somehow we're doing a bad job on the weekend. The other one is higher acuity on admission. What would the temporal signature look like if you compared one to the other? And what should we find in the data? So the first pattern would be, look, if people are being admitted with higher acuity illness, then they're being exposed to care as it is. And the difference between the two populations should therefore be the same, irrelevant of weekend. There should be no weekend effect. In other words, things shouldn't get better during the weekday. If these people are just sicker people, then they're always going to be sicker. Does that make sense? Yeah? If it's weekend effect due to poor care, then you're going to see something like this. So this is excess mortality, right? So people would get admitted. You'd expect to see some sort of peak in mortality due to the poor care on the weekend. But then over time, as they get re-exposed to good care on the weekday, then you should see that excess mortality disappear. You should see that. So really, these are the two competing temporal signatures that you'd expect to see in the data if it was one or the other. And that allowed us to create really 4 separate hypotheses about what the time signature should show. So the first here if there was no weekend effect, you should see nothing. H1 is if it's pure weekend effect, you're going to see just that peak, which reduces to 0 sometime during the week. If these are sick folks, they're going to be sick, at least in short run all the time, or you might have both things happening. So you might have that mixed picture. Okay, what did we see? We saw both. So there was only one pure weekend effect, which was quality of care. And these are the acute cardiovascular events, infarcts, etc. And these folks had a very clear pattern of increased mortality on the weekend, which disappeared very quickly once they got re-exposed to care. Presumably they're all dead. I don't know. Then all the respiratory events showed the same washout, but washed out over a longer period. Everything else, all the cancers, for example, show this is really statistically a straight line, and these are higher acuity patients presenting on Friday evening or Saturday, presumably because they're in primary care during the week, and the GP has said, look, it's Friday, you're not doing well, I need to admit you. This is really probably poor planning if you think about it, and a little bit of mixed effect here, but. So you can really see the bulk of what's going on actually is higher acuity for interesting reasons. But at least one group, the respiratories and the cardiovascular events really seem to suggest something about quality of care. So that's really interesting because that says there's no simple answer to this complex problem. There's different things happening for different groups of patients. I think that's just what I said. So we'll move on. Okay, this picture is to remind you that sometimes you need to take the thing that's familiar and think about it differently. And so we were very pleased with ourselves when we did this work. It got good attention when we published it. And, we started to think about, well, what do we see in the data? I mean, if you do your standard analyses, this is what you see. Can we bring different eyes to the data and maybe find something else that's going on? And so we thought, well, what we're doing, we're looking at temporal signatures here. Where is the body of knowledge for this? And the body of knowledge comes from biomedical signal processing, patient monitoring. All of that I've talked about is standard signal processing over time. And can we bring those methods and those ideas over to what we're currently looking at really as an epidemiological or statistical challenge? Are we making any mistakes? And do people know what aliasing is? Aliasing effects? So you should. So this is a very simple problem in temporal analysis. So imagine I've got some time-varying pattern. The curve I recover depends on how frequently I sample, right? So, and the Nyquist rate says you've got to sample twice as fast as the frequency of the signal. So the aliases are the patterns I recover when I'm sampling below double the frequency, the Nyquist rate. And so if you sample too low, you're actually getting the wrong pattern. So when we started thinking this way, we thought, well, what might the appropriate sample rate be? Because what I've shown you is this. I've shown you the weekend effect, which shows that mortality rates peak on Saturday and Sunday, and that's what the literature shows. But what happens if we were to sample more quickly? What would we see? Thoughts? Again, not a trick question. You see this. So there's not a weekend effect. There's a daily effect. There's a 7-fold difference in mortality rates depending on time of admission, which makes sense because your planned admissions are happening in the morning and folks who are coming in the evening are going to have different issues. There's a difference in peak and duration, which is why you see the weekend effect. But we don't have a problem on weekends. We have a problem right through the week, and really need to be thinking about service of care in a very different way, probably. So this is really interesting. So the next step was to say, well, okay, what can we do with that information? So, as I said, one of our interests is in building predictive models. Go. Yeah.
So, what is the interval of sampling? Because it seems to me that the lower graph, if you sort of tallied up the 24-hour time periods, shouldn't give you the upper thing, unless I'm missing something.
They do. It's just one thing is to look at how fat these humps are. So if you look at area under the curve, think of it that way. Okay. Yeah. So I think our sampling was 4 times a day.
So, maybe you're going to get to this, but one thing this immediately makes me think is, who cares about planned admissions? if you just can categorize them by planned admissions, irrespective of hour of a day of admission, that the rate of mortality, the risk of mortality would be so low. If you exclude all those, what kind of pattern do you see? Do you still see a sort of nighttime admission pattern, or does it really flatten out a lot more?
Oh, yeah, so we haven't done that. Good question. But I think at this point, this is his current work, the question is, well, now that we know this, what should we be looking at? And the use that we've put it to is to build a predictive model. So basically to say, look, we could predict your risk of death, for example, based on standard statistics. And those models, you know, have sort of ROCs about 0.8, something like that. Let's now calculate your risk of death based on time of admission. Let's see what that does. And when you just add in that temporal value, then the models start moving up to the 0.95. So they're much more powerful models. So this sort of does what you suggest in a way, which is to say, look, based on knowing who you are and when you arrived, I know a lot more about what your risks are. So in a sense, that's exactly what we did do. And that came out just about 9 months ago. So this really says that those temporal signatures carry really important data about you and your risks, and you should do something based on that much more personalised model. So it's still early days. It's kind of fun. We're still looking at very high-level administrative data. So go.
Can you go back?
I hate the back button.
Previous slide. I actually realized why, as you were switching the slide, I didn't look at the y-axis. I assumed that the baseline was something really low, but so you know, now it makes much more sense that the data adds up under the curve, but that's a potentially misleading slide or potentially misleading graph.
Oh. But it's exactly the same data.
Yeah, no, I understand that.
Yeah.
So do you think that this represents a variation in care or a variation in patients?
Well, this is the same data set. So the answer is it represents both. And depends on what you want to do with the data. So if you're interested, it still shows, for example, that weekends, these are the worst bits for sure. Just look at the area under the curve. So if you're going to focus, you should focus on that. So the thing that we need to do now, for example, is to say what was going with the CVS events? Why were these folks doing so badly? And our data set involved both rural and urban hospitals. If you're in the city, you're going to get your stent and your imaging within an hour or so anyway. On the weekend, they're centres of excellence, so that's not going to be an issue. But if you're rural, you're not. And so our guess is that really what we're seeing is probably not an effect of major centres of excellence, but probably poor delays in care. You know, we got in a lot of trouble when we published this paper from our state because you said, you know, you're representing our state as delivering really bad care. Some people still don't talk to me in the Department of Health. And our message was not that this was bad care, but this was probably the result of delay in access to care. And the message of the research is not don't go to hospital on weekends at all, but get in there as early as you can. That's the way you should see the data. But you can imagine how the media portray the data set.
So you're in the process of stratifying this out, breaking it out by, you know, rural and urban and larger and smaller,
that's a sort of, exactly.
And also, you know, medical condition like you did with the other stuff. Yeah. Yeah. I mean, it's interesting. I wonder how much of this represents, you know, people getting admitted with when they didn't want to. You know, it's like, you know, who wants to be in the middle of the hospital at 7 p.m. on a Friday night, right? Unless, you know, it's almost like self-selecting.
Yeah. But so, for example, when you compare injuries, you know, somebody turns up, that's not driven by your choice, but there's no excess mortality on weekends for trauma. You know, your risks are the same weekday, weeknight. So that service, the ED service, and presumably the emergency surgical services are set up to handle you in the same way. So it's not that people are turning up with you know, broken bones from football or something. Okay. I think that's it. Thank you.
Thank you for your talk. I hope you don't mind if I ask a techie question.
Go.
Does the fact that you're using EHR brand X, Y, or Z make it easier or harder to pull this level of granular data?
So what's interesting about these data sets is that they are administrative report data. So this is the stuff that most hospitals would report anyway centrally. So the data we're looking at now is that more granular EHR data for the sort of the predictive models and the forecasting or the green button technology. But what you're seeing here is just run-of-the-mill state report data, nothing special at all. For the labs, the lab results, we were lucky that we had a homegrown EHR and that they were willing to put timestamps into the system. So when I spoke to Gordy Schiff over at Partners, who wanted to repeat the study, he was not able to because they wouldn't put the timestamp in on the read. So very frustrating for him. So I think it's not so much access to the data, but it's being able to instrument the data set. So remember, what we're doing here is we're very interested in the behavior of the users over the aggregate. And I think that's the thing that people will struggle with, which is being able to convince either the vendors or your local groups to put in those little logs that you want.
Well, okay, I was just going to, actually it ties back to your comment in the beginning about Chris Longhurst's green button, which actually gets its name from the blue button, which is the VA blue button that you can, as a patient, you can download. But this actually makes me think about the green button because even though I'm, fascinated by the opportunity to learn from data that's sitting there in the system, I think your sort of drilling down into the details of your data show problems with that approach. Looking at data that's sitting in your system because at the sampling interval, for example. Are you doing anything else with the green button, and do you have any concerns about you may find something that is really due to a confounder or something like that?
So we're not worried about confounding because we sort of understand how to handle that. So the model really is that you need to pick a matched cohort of patients that are significant statistically. So you appear, you've got diabetes, heart disease, and a bunion. I've got to make a choice about how close the patients are to you to create that artificial cohort. And so what we're working on is on how you would select the boundary. And we see basically the boundary as a slider. So for some patients, you're going to have so many similar patients that it's going to be significant statistically, it's going to be very powerful. I can find people very close to you. But for others, the rare diseases, that slider, to get a cohort that matches, will start to incorporate all sorts of odds and sods. And so probably what we're thinking is that we need to give you a sense of the quality of the match before you move forward and make a decision. And so it's not simply hit the button, here are 100 people. It's, well, actually can only find 20 people that were useful, and they're not that significant really because what you've got is really quite unusual. So that's, I think it's, rather than saying it's a problem, it's something we need to expose and make you realize you can't always use the data in that way.
This work really makes me think about a couple, besides data and information quality in general, which has been really interesting for us in terms of trying to start to think about that operationally as far as research is, what can the underlying data, it's time, the person, the role of the person who's ordering or reviewing the data, the organizational structures in which they practice, what can that tell you about whether this is due to something about the patient or something about the system of care, and then how can that be used to inform actual quality improvement, right? Because, the work here, you sort of heard people saying, well, I don't know, what's the real cause of this? As you progress with this, what are your next thoughts about what kind of studies you design to start to look more deeply at what's due to the system and which parts of the system versus the underlying patient?
Yeah, look, I think the high-level response is the one that I've already given, which is that I think unguided analysis of the data is a waste of time. You look at 1 million data variables and you're going to find correlations. You really have to be driven by questions. And you have to be driven by questions driven by your service and your own insights and intuition. So, having a bunch of data scientists who don't understand the workflows doesn't really bring you much. So you really need, this is really a partnership of people who actually have deep knowledge about service and what the problems are, as well as the people who have those really important skills around the analysis. And so we got stuck a lot, and things unfolded only when we went back to first principles and said, what do you think is really going on here? And surprisingly quickly, we found things. Yeah.
I've been thinking about your slide where you showed all the conditions that had higher mortality on the weekend. And a question that came to mind is I'm wondering if there's anything that has to do with continuity of the care provider and weekend coverage, where maybe some of those conditions, you have a care provider that has longitudinal knowledge of you, whereas in trauma, you don't tend to have that relationship.
So it's hard to answer with the data set we've got. We had a cancer specialist on our team for the data because of the large proportion of cancer patients. And he said, look, the most obvious workflow issue for me is actually that there is a late handoff of the patient to the hospital on the weekend. And really what should have happened is Tuesday, Wednesday, Thursday, the patient's deteriorating. They should have come in a planned way, not as an emergency. I mean, with the cancer patient, you shouldn't be, Friday evening, Saturday morning, depositing lots of people in who are just all of a sudden not doing very well. That's a failure of handover and a failure of planning, I think. So that's as close as we've got to answering that question. But I think you're absolutely right. It's got to do with this, understanding what the needs are of the patient. Yes.
Are there any plans or discussion about, using this for more like hypothesis testing than hypothesis discovery? Because now that you've got a way of characterizing and measuring something, this sort of follows up with David's question about, how to use this to improve care, and then you could follow up with the measurements to see if it actually improved care, if it did reduce the variation, these timings and that kind of stuff. And how what are your thoughts about how you'd actually set something like that up?
I think it gives you the tools then to do that. I mean, this is still fairly recent for us. What's worrying is that some hospitals have already changed practice based on our results. So, a couple of hospitals in another state back home said, "Oh, we've gone 24/7 on now. We've got better coverage," which is fantastic. Natural, but unplanned and unstudied. Yes. So it's a wasted opportunity. So, which is what happens with all quality improvement in the end. It's just these are wasted opportunities often.
You have the before and after sort of anyway.
But as a scientist, I'm not happy.
Right.
I've got to do hypothesis testing. It's got to be prospective.
Yeah.
Joan.
So I'd like to get you talking a little bit about communication, and it seems like your results from the test result follow-up study lend themselves to some thinking about how communication should be happening. What do you think?
Yeah, that really underpins the sort of suggestions we've made around what one should do. And so it makes no sense to me that 50% of these tests that are looked up just get done on day of discharge. That is a massive failure of somebody telling somebody an important piece of information. And when you do the qualitative work that we've done, it's often just a failure to know that the patients are going home. So that who's made the decision to go home? Is it planned or unplanned? And why haven't you told the people in your team that they're going home? Why is this battery of tests being ordered? The other thing that the labs say is that they're very bad at communicating how long it will take for a result to come back. There's sort of magical thinking, I'll put the test in, it'll be back today. But some tests get batched up and only get done once a week, for example. You may not see a result for some tests for a week or more. So is that going to change your care? in the next 2 days? Maybe not. So I think underpinning those issues are communication solutions, for sure.
Along those same lines, do you find that discharge order sets may be partially to blame, that we're just ordering batches of stuff? And conversely, in the States, ordering single tests is the payers like that better than ordering test panels like a chem panel. Does that have the opposite effect of making them more likely to be followed up?
More likely to be followed up? We don't know. So one of the things I'm interested in is what I would call inertia. In other words, the ability of people to respond to different signals about what's going on, and the failure of people to respond to important signals. So the next piece on that, which we're writing up now, so don't go and do this, is looking at the signal in the lab test result in terms of whether it's normal or abnormal, and does that affect the follow-up rate. So, my intuition is if I'm ordering a test for a patient who's sick, as a physician, I'm probably going to be wanting to get that result. You're unwell. I'm ordering it for a reason, so therefore I'll be following that more likely than if the patient's results come back as normal. It turns out that there's no difference in behaviour depending on abnormality at all. In other words, we think it's workflow driven. That basically that there is so much work to be done on the shop floor in the hospital that people's capacity to respond to signals is so low that it's not changing follow-up behaviour. So I still really think that a lot of what we're seeing is just driven by the way the machine is built, and I don't think it's a cognition issue. I don't think it's an issue about training necessarily. I think there are prompts and nudges you can provide to get people to do things, but I think this is a Starling law. This is how tests get followed up in this hospital, because you've built the hospital to produce this curve. So if you reproduce that here, I guess you're going to get the same shape curve, but I think it'll have different values, is my guess.
So the thing with abnormal values that's so tricky, and this may relate to your tomorrow's activities that you're engaged on, is that most abnormal values are meaningless. They have no meaning because it really depends on the patient. Like if you take creatinine, which is one of the most commonly ordered labs, it really is what is their creatinine usually, and is this different in some way? Is it better? Is it worse? And so for every patient, for some sets of lab, the abnormal rules are set very poorly. They're technically abnormal, but they're not meaningfully abnormal. And for some labs, it's very patient-dependent, where I expected abnormal lab. It's how abnormal it is that really matters. Not to say that, not reviewing it is acceptable in either of those cases. It's just if you do set thresholds or sort of try and ask specific questions looking for that, probably your models will be much better. Is this creatinine that was unreviewed worse or better than the previous one, even though it's abnormal?
You're right, and you could absolutely do that. But don't forget, one of the underlying reasons we study this is because an unfollowed up test is an economic cost. Yeah. So why did you order the damn thing? Even if these are all, from information theory, adding no information to the pool at all, then you shouldn't have ordered them necessarily. So I think either way, it's still problematic. But you're right.
Difference between commonly ordered tests and rare tests in terms of follow up with the results?
We didn't see that. I think there was only potassiums were different, and I think they were probably the only ones. And I said even there, the workflow, they were one of the few tests where the lab workflow was very different, where they was put a phone call through to the ordering physician anyway. So the rest was all through the CPOE system.
Okay, well, thank you very much.
My pleasure. Thank you.